Hi everyone. In this video, I'd like to review two medications that we use to treat atrial fibrillation with a rapid ventricular response. And those two medications are Verapamil and Cardizem. Now, gotta go back quick and just take a look at AFib. Remember, in atrial fibrillation, the atrial chambers of the heart are just quivering. They're not fully contracting, and this carries a couple important liabilities. One, because the atrial chamber is no longer contracting, it's no longer adding the atrial kick or that amount of blood to the ventricles that gets kicked off during one beat. That stroke volume has been reduced. And they say because the atrial chambers are quivering and not contracting, you could lose about 20 to 25% of your overall cardiac output per beat. It reduces your stroke volume, that's the amount of blood ejection during one contraction, by about 20 to 25%. The second problem with AFib is because the atrial chamber is just quivering, not contracting, there's areas in the atrial chamber where clots can form. And that's the big risk with AFib, the formation of clots. If it happens in the right atrial chamber, clot forms, breaks free, goes to the right ventricle, up to the lungs, you just bought yourself a pulmonary embolism. If it happens on the left side, left atrial chamber, goes down to the left ventricle, out through the aorta, up through the carotid, to the middle cerebral artery, and you just bought yourself a stroke. So those are huge risks when it comes to AFib. But we're talking about AFib with the rapid ventricular response, and that's a ventricular rate over 100. Now, if you think about it, in AFib, we lost our atrial kick, so we already lost maybe 20-25% of our stroke volume. Then we lose our filling time because of the rapid ventricular response. So AFib with RVR can really impact their cardiac output. Now, these two drugs, Verapamil and Cardizem, are not to treat the AFib. That's not why we're administering these medications. These medications are used to control the ventricular rate. That's it. And honestly, we may not want to put them back into a sinus rhythm until we make sure they haven't developed any clots. So any new onset AFib greater than 48 hours, we're not going to cardiovert them or try to put them back into a sinus rhythm until we've done an exam like a TEE, a transesophageal echo, and we can go down and we can look at those atrial chambers and see if any clots have formed. The patient will also be anticoagulated, receiving heparin. Now, let's take a look at these two drugs, Verapamil and Cardizem. And it appears that Verapamil is more popular in the field and Cardizem is more popular in the hospital. Why is that? The short answer is because Cardizem needs to be refrigerated. That's it. Cardizem has to be in the refrigerator. Now, I spent 10 years on a hospital-based critical care team, and I'm transporting patients on Cardizem drips all the time, and the doctors would say if they have some breakthrough tachycardia, give them this much Cardizem. Okay, in order for me to have Cardizem in my ambulance, I had to have a refrigerator. That's what I did. Went out and bought a small refrigerator, made sure that my inverter could handle the power, and I kept all my refrigerated drugs in there. Same thing when we were flying in the aircraft. Had the big drug bag, had our goodie bag, which is our narcotics, then we had our cold med bag, which would have our Cardizem, Sux, Ativan, all that stuff. So some medications need to be refrigerated, and that's why you just don't see Cardizem that often in the field. Now, let's talk about the dosing of these medications. Cardizem, if you look in the book, your starting dose is 0.25 milligrams per kilogram. You can repeat that with 0.35 milligrams per kilogram. And if you get the heart rate to slow down, you can start an infusion of 5 to 15 milligrams per hour. That's the dosing of Cardizem. Verapamil, generally 5 milligrams, and if you read the book, 5 milligrams over 2 to 3 minutes. I don't like that, and I'll tell you why. Verapamil undeservingly got a less than savory nickname out in the field. And what do we call Verapamil? Talk to an old paramedic? Yeah, they call it Verapakill. And here's why I think it got that nickname. They were pushing the drug too fast, period. Now this is anecdotal, of course, I have no science, but that's what I'm thinking happened. When I went to paramedic school 30-something years ago, my great mentor and teacher who really impacted my career more than anybody else, and I don't want to say his name because I'll embarrass him, Dr. George Gallant, told me when administering, at my paramedic class, when administering Verapamil, the dose is 5/5. That means 5 milligrams over 5 minutes, a very slow push. Anytime you are injecting a calcium channel blocker into the body, this can cause bradycardia, hypotension. Both of these drugs are class 4 antiarrhythmics. They're calcium channel blockers. They dilate smooth muscle, they can dilate the coronary vessels, and you could drop someone's pressure very quickly if you administer a calcium channel blocker too quick. Cardizem, at least 2 to 3 minutes. Verapamil, 5 minutes. Now, I know that's not what the book says, but I've always done that and I've never had an issue with it. Now, back in the day, before adenosine became popular, we used to use Verapamil for all these neurocomplex tachycardias. We would use it for SVT or AFib with RVR. And often in the field, it was difficult to tell the difference. Still is. Any stable patient with a narrow complex tachycardia, and you're wondering, geez, is that SVT or AFib with RVR? Get a 12 lead. So, what's the takeaway from this video? Both of these drugs are class 4 calcium channel blockers, and calcium channel blockers need to be administered slowly. Time it. Cardizem, at least 2 to 3 minutes. Verapamil, 5/5. I'm Mark, thanks for watching. Thanks Dr. Gallant for everything. I'll see you guys in the next video.